Good morning, everyone, and welcome to our webinar on the recent report from the Health Foundation, Health Inequalities in 2040. And this webinar, we're going to focus on the current and projected patterns of ill health in England by deprivation. We're really pleased you've been able to join us. Just a few things before we start. First is to tell you that this event is being recorded. And we will be making a recording on our website available very shortly after the webinar. We also will be then providing a version with captions, a subtitle version that will follow shortly. In terms of the structure of the webinar, we're going to be starting with a presentation with the lead author of the report, Anne Raymond, and then we will move into having some panel discussion before we open up to questions from the audience. So I wanted to bring your attention to the Q&A function, which is where you can put in your questions you would like us to put to the panelists. People can also upvote questions so that we can see where there's most interest and guide the discussion to that. And we'll be looking out for things that sort of particularly catch our eye and speak to the expertise of the panelists that we have. So that hopefully kind of just gives everybody a sense of how we're running this event. So just say, I'm Jo Bibby, I'm the Director of Health at the Health Foundation, and I am responsible for our portfolio of work on improving health and reducing inequalities. And really pleased to be having this event, and particularly the really great expertise and breadth of perspectives that we're bringing through our speakers and panelists. So you'll be hearing from everybody shortly, but just to introduce people, we're joined by Anne Raymond, who I said is the lead author of the report. Anne's an economist at the Real Centre, which is a Health Foundation strategic initiative. We're also joined by Nye Cominetti, who's a principal economist at the Resolution Foundation, Dr. Sandra Husbands, who is Director of Public Health at the City of London and London Borough of Hackney, and also Steve Eiley, who is Chief Medical Officer at Jaguar Land Rover. So I think this is a really great panel because the report, as we'll hear as we go into the slides and presentation, raises some really quite profound issues for us as a country in terms of future health of the population, how it's patterned by deprivation, and also particularly some of the issues it's going to be presenting for future working age health. So with that, I'm going to hand over to Anne, who is going to kick off by sharing the highlights of the report.
Great. Thank you so much, Jo. I will just begin to share my slides. Yeah, so hopefully that should be visible to everyone. So my name is Anne Raymond. As Jo mentioned, I'm an economist at the Health Foundation, and today I will be taking you through the findings of this recent report that was published earlier this year, looking at health inequalities in 2040, where we explore current and projected patterns of illness in England by socioeconomic deprivation. And this is work that we did in partnership with our academic partners at the University of Liverpool. So just to provide you with a bit of quick background and context into this work and why we think this is important, obviously health inequalities are now becoming an increasing focus for policymakers, particularly after the pandemic. There has been a lot of research into this topic already within England. We know of the existence of wide health inequalities by different characteristics, actually, by ethnicity, by deprivation, by region. These are all quite well documented. And within this research, we are particularly focusing on health inequalities by socioeconomic deprivation. So for instance, within England, if you look at the people living in the most and the least deprived areas, there is a life expectancy gap of 8 to 10 years. And if you look at the healthy life expectancy gap, which is the amount of time that people are expected to live in good health, that gap is actually double the life expectancy gap at 2 decades between people living in the most and the least deprived areas. So what is it that this report is adding to what is already out there? A lot of the commonly used measures of health inequality, so things like I mentioned, healthy life expectancy or disability-free life expectancy, they actually use self-reported health. So they are based on surveys asking people how they would rate their health. And so what we are using is data, very granular data on illness from patient records. And so using this, we are able to explore health inequalities in a lot more granular and detailed fashion. Like, for instance, we are able to look at the specific long-term conditions that are contributing to health inequalities. So that is one. The next thing is, to our knowledge, this is actually one of the first studies to project what the future of health inequalities are going to look like in England. And then finally, a lot of the findings that I will be showing you will be focusing on the working age population to show how patterns of health inequalities play out within that population, and to see how this can have much wider implications beyond health for things like local economies, labor markets, and wider economic growth. So just to provide some quick introduction into the program of work, this is a long-term program of research, the Health in 2040 series with the University of Liverpool. We had a first report looking at overall projections of illness in England come out last year. And this is the sort of second report in the series looking at health inequalities and doing this deep dive by socioeconomic deprivation into patterns of illness. We have better data. So like I said, we have very granular data, which links data from GP practices with hospital records, and then death registration data as well, that allows us to look at these patterns of health inequalities in a very detailed fashion. The partnership with the University of Liverpool allows us to access this very sophisticated model that gives us a better understanding of the relationship between long-term illness, aging, and multimorbidity. And what the model also does is it incorporates trends in risk factors. So things like BMI, smoking, alcohol, diet, physical activity. It basically looks at how, if the trends in those risk factors were to continue into the future, what does that mean for illness based on the academic evidence that we have of the relationship between these risk factors and long-term illness. So if we assume a continuation of trends in risk factors, based on the relationship between risk factors and illness, what does that mean for the future of illness and population health, and how is that going to be distributed by deprivation? And then finally, how we measure population health or ill health is also quite novel. So a lot of times we use numbers of conditions in research, whereas what we use here is actually something called the Cambridge Multimorbidity Score rather than numbers of conditions. And so this is an aggregate score for illness, which assigns a weight to 20 common long-term conditions based on their impact on healthcare use or based on the likelihood of death with having that condition. And essentially, what we can then do is, if somebody has multiple conditions, you are able to add up the scores for the different conditions to get an overall illness score. And so that's what we use here. And in a lot of the findings, I will be talking about major illness, which is essentially our proxy for illness that involves high healthcare use or high risk of death. And we define this as somebody having a Cambridge multimorbidity score greater than 1.5. So that 1.5 threshold is what we're using to define as major illness. So going forward, a lot of my findings will be focused on major illness specifically. Right, so what do we find? What are our key findings from the report? So basically, on current trends, if we assume a continuation of trends and risk factors, we find that health inequalities will persist on to 2040. People in the most deprived areas can expect to be diagnosed with major illness 10 years earlier than people in the least deprived areas. We also find that out of these 20 conditions measured by the Cambridge Multimorbidity Score, a small group of 7 contribute to pretty much all of the health inequalities that we see. And out of those 7, conditions like chronic pain, type 2 diabetes, and anxiety and depression are projected to increase at a much faster rate in the most deprived areas on to 2040. We also are able to, like I mentioned earlier, look at working age ill health. So by working age, we define this as people aged 20 to 69 years. And we find that the number of working age people with major illness is projected to increase from 3 million in 2019 to 3.7 million in 2040. We also find that this increase is not going to be evenly distributed. This is going to be concentrated in the more deprived areas. And then if we look at action and in terms of the implications of what this means, obviously prevention and population health policies are going to be quite important. And so action focused on risk factors, will be quite important. But that on its own would not be able to solve some of these issues. It has to be accompanied by a long-term effort across government and the economy on the sort of building blocks of health. So things like income, employment, housing, and all of these things that we know affect health. So let's go into some of these findings in a little bit more detail and see what they look like. So when we look at the current landscape of health inequality based on the data that we have, what does that look like? So similar to what we've seen with self-reported health, so I told you about that big gap that we see in healthy life expectancy. We also see a similar pattern when we look at illness based on healthcare records. So this chart is showing you the share of people with major illness by age group and by decile of deprivation. So we use something called the index of multiple deprivation, which is quite commonly used in healthcare research, which ranks every small area in England based on how deprived the area is relative to other areas. And so here what we're seeing is this is grouping every single local area into a category of 10 equal groups. That's essentially what we're seeing here when we say decile of deprivation. And so this is showing you the share of major illness by age group and decile of deprivation. Very clear pattern of inequality coming through. You can see that the share of people with major illness is always greater, the more deprived an area is. And you can see that sort of manifesting very early on. So even in the 20 to 29 age group, when levels of illness are quite small, you are still seeing inequality there. And then that sort of continues to grow throughout adulthood until you reach the oldest age group, the 80 plus age group, where it looks like health inequalities are leveling off. And that is because people with the poorest health in the most deprived areas have already died by the time they reach that age. And so there is actually not a lot of difference in the health of the surviving groups when you look at deprivation. And like I mentioned, the data that we have allows us to look at the specific conditions that contribute to health inequalities. And so out of the 20 conditions that we looked at, a group of 7 contribute to most of the observed health inequalities. And these are things like chronic pain, anxiety and depression, type 2 diabetes, chronic obstructive pulmonary disease or COPD, and a group of cardiovascular conditions, so things like coronary heart disease, stroke, and heart failure. And again, this chart is showing the share of people with these conditions by decile of deprivation. And again, you can see that socioeconomic gradient that we have seen with a lot of other health inequalities measures manifesting itself here quite clearly. And then, just like I said earlier about healthy life expectancy, we can use a similar the calculation underlying healthy life expectancy to make our own sort of version of healthy life expectancy based on diagnosed illness. So, for instance, here we can define what we are defining as healthy life expectancy here is time without major illness. And so that is what the red section of the bar is showing here. And the green section of the bar is showing the amount of time that people can spend with major illness. So this is total life expectancy, which is the total length of the bar, broken up into the amount of time that people can spend without major illness and the amount of time that people can spend with major illness. And this is for women, the chart here. And you can see that there is a 10-year gap in the amount of time that people can spend without major illness for the most and the least deprived areas. So people in the most deprived areas can expect to be diagnosed with major illness in their early mid-60s, whereas women in the least deprived areas can expect to be diagnosed with major illness in their mid-70s. And so it's not just that and this gap is actually quite similar for men as well. So the major illness-free life expectancy gap of 10 years is similar for men. And so it's not just that, for instance, in this case, women are living shorter lives. They are also living more of those shorter lives with major illness in the most deprived areas. So that's sort of setting the scene in terms of what the current landscape of health inequality looks like. What do we expect is going to happen in the future? What is going to happen by 2040? So if we assume current trends and risk factors, this 10-year gap that you see, it is going to stay the same. So this major illness-free life expectancy gap between the most and the least deprived areas of a decade that we are seeing now will continue on to 2040. There is going to be no change. And so essentially, we are going to see a stubborn persistence of health inequalities into the future. And like I said, we can see how this is going to affect working age ill health as well. And so we are able to look at, so this is the population aged 20 to 69 years that we are defining as working age. And what we see is we see an overall increase in working age ill health from, so the overall number of working age people experiencing major illness will increase from 3 million in 2019 to 3.7 million in 2040. But what we find is that that increase is not going to be evenly distributed. 80% of that 700,000 increase will be in the more deprived half of the country, so deciles 1 to 5. So that's what the chart is showing. The chart is showing the population change between 2019 and 2040 by deprivation, and how much of that is down to people with major illness and how much of it is down to major illness. And you can see a clear concentration of that working age ill health happening in the more deprived areas. I'm sorry, I'm sitting in a meeting room and the lights just went off, sorry. Right. And again, because the data allows us to look at the specific conditions, we identified these 7 conditions that contribute to health inequalities. What is going to happen to these conditions by 2040? So this is showing the change in the share of people with these conditions between 2019 and 2040. We actually see a very different picture for different conditions. And so if you look at the right-hand side of the chart, so you can see a very positive public health success story coming through. So smoking-related diseases like stroke and coronary heart disease, they are projected to decrease across the board, but also decrease more in the most deprived areas. So we are going to see a narrowing of inequalities for those illnesses. And this is in no small part because of the public health policies that have been implemented over decades to reduce smoking. And because we know that people in the more deprived areas are more exposed to smoking, which means that any policies targeting smoking will have a bigger impact there. And so that is why we are seeing a bigger decrease in smoking-related diseases like coronary heart disease and stroke. But if you look at the left-hand side of the chart, you are seeing a sort of an outcome that we don't really want to see going into the future, which is type 2 diabetes increasing across the board, but also increasing more in the most deprived areas. And so we are seeing a widening of inequalities there. And this is because, as we showed in our first report last year, we are projecting that obesity will actually slightly increase going into the future. And we know that obesity, people are more exposed to obesity in the more deprived areas. And so again, you are seeing that sort of knock-on effect of that, of a bigger increase in type 2 diabetes, which is quite closely linked to obesity in the more deprived areas. And so a widening of inequalities with type 2 diabetes. And then finally, what does this mean for the numbers? Earlier, we were seeing the shares of people with these conditions. What does this mean for the numbers of people? Because it's quite important to understand how do you allocate healthcare resources? What does this mean for healthcare demand? And so within those 7 conditions, these 3 conditions are actually the most prevalent across both the most and the least deprived areas. So you have chronic pain, type 2 diabetes, and anxiety and depression being the 3 most prevalent conditions across the most and the least deprived areas. That is the case in 2019. That will continue to be the case in 2040. But the difference is in how much of that growth is what the difference in that growth is. And that growth is going to be much faster in the most deprived areas compared to the least deprived areas. And that's what we're trying to show here. Right, so finally, what does this all mean? So we found that based on our research, wide health inequalities are projected to persist with far-reaching implications for health and the wider economy. And this is if we assume a continuation of trends in things like smoking, alcohol, obesity continuing into the future. This is what we see. And obviously, this has huge implications for people at an individual level with the early onset of major illness in the more deprived areas. But also, if we look at, for instance, from a healthcare resourcing angle or a healthcare demand angle, this has huge implications. So like I said, some of the biggest growth is going to be in things like chronic pain, type 2 diabetes, anxiety and depression, which are all conditions that are largely managed in primary care. And so these are which then means that primary care will need significant investment going into the future. But we also saw that the growth is going to be much more in the most deprived areas. And so there is, obviously, it's quite important when we think about the distribution of these resources and in terms of primary care already in more deprived areas having, for instance, fewer general practitioners relative to health need, and there is an imbalance relative to need. And so thinking about how we correct this imbalance if we are going to see this big growth in some of these conditions in the more deprived areas. Like I said, a lot of these trends are down to risk factors, and so prevention has a huge role to play here. We have seen the success of, for instance, smoking policies playing out through the narrowing of inequalities in conditions like coronary heart disease and stroke. And so again, prevention, a huge role to play, and we need population-wide government policies tackling the biggest risk factors. But that will not be sufficient on its own. This has to be accompanied by long-term effort across government and the economy to address the building blocks of health. So things like income, housing, employment, transport, access to green space. We know that all of these things also have a role to play in health, in people's health, and they are also patterned by health inequality, and so quite important to look at those policies as well. And so again, this is not just a health issue, as we saw with the growth in working age ill health. This has now become a big policy issue. We see that that growth in working age ill health is not going to be evenly distributed. It is going to be concentrated in the more deprived areas, which risks exacerbating existing economic inequalities. And it also risks limiting economic growth and labor supply, worker productivity, local economies. It has implications for all of these things, so very important. We also have separate health foundation research looking at how there are now as many people in work with work-limiting health conditions as people out of work. So it's also not just a question of people dropping out of the workforce because of ill health, but also thinking of how we can support people to be in work and to contribute in the way that they think meaningful when they are in work. And so employers have a very important role to play here as well, thinking about how do you support your workforce with different health conditions. And then it also has implications for things like the upcoming increase in state pension age. What does that mean if you have a big group of people in the more deprived areas in the country getting major illness earlier and having to wait longer to access their state pension? What does that mean? Does that risk having people putting people into financial hardship if they have to drop out of the workforce, for instance, because of ill health? And so I just wanted to end by saying this is a very key topic. This has massive implications, not just for health, but also for wider economic growth and for people's ability to contribute to the economy through work and local economies and labor markets. And so we absolutely have to think of this as a prerequisite. Tackling health inequalities should be considered a prerequisite if we want a future with economic prosperity. So thank you very much. I think I will now hand over back to you, Jo.
Great, thank you very much, Anne. I think a really excellent presentation covering what is a very rich report. I think if anybody hasn't had a chance to look at it yet, please do. there's a huge amount in there, and I think some really sort of quite groundbreaking findings as well. So I say we've now got a chance to sort of move beyond the report and start to do a little bit of reflection on the kind of so what might this mean. We have the Q&A. I've seen people have been putting in some great questions specifically about aspects of the analysis, lots of quite detailed questions, and a big shout out to our colleague Toby Watt, who is a co-author on the report and providing some very excellent responses to those questions. But as we move out sort of into the implication space, I think we're fortunate we've got three different perspectives really on the panel. We've got Nye, who kind of does a lot of work on low pay. He helps with setting living wage. He's a labour market economist. We've seen that there's implications for working age health. We have Sandra, who is hugely experienced at sort of national and local level in terms of the role that the public health system in its broadest sense can play. And then Steve, as somebody who has been chief medical officer in a range of different industries, and sort of this whole question of working age health, I'm sure it's very top of mind at the moment. So I'm going to start off by just asking each of our panelists to share a little bit of their sort of headline reflections on the report, and then I'll follow up with a few more specific questions. But in the meantime, please do start thinking of some questions you'd like to pose to the panelists and put them in the Q&A. So I think the order I'll go in is Sandra, Nye, and then Steve, I think. So Sandra, could I turn to you first?
Thank you very much, Jo, and thanks very much, Anne, for that excellent presentation of a really excellent report. I really welcome this report. I know colleagues of mine in public health have been very interested but also supportive of having this report because it so comprehensively sets out the case for doing something about health inequalities. And I know that we talk about this, and we've been talking about health inequalities for many years actually, all the way back to the Black report, but haven't really been able to say, well, what do we think it's going to look like in another 20 or 15 years before? So this projection angle of this report is novel and also really helpful because it kind of gets you to understand that this is a looming disaster, as opposed to at the moment people thinking, well, yeah, there are these differences, but it's all down to their lifestyle choices and not having worked hard enough at school, therefore they didn't get a good enough job, and if they're poor, they really just need to pull themselves up by their bootstraps. The reality is that health inequalities are driven by much more entrenched factors, and the accident of your birth, not just where you grow up, but which family you grew up into, and all the factors that have affected that and your family over their life course and you over your life course are things that are way beyond your control and beyond individual responsibility. So it's really helpful as well to see set out so clearly in an evidence-based way in this report how all those building blocks of health are playing into not just health itself, but health inequalities. And health inequalities are also really important for us to understand as an indicator, if you like, of the health of the population as a whole. So they're not just telling us that some people have worse health, they're saying actually as a whole, this is an issue for us as a population, as a public health system, as a health system, and as a government and an economy. It's not just a question of some people have poor health. Health inequalities are telling us there's actually a gradient, and we're all somewhere along that gradient. But if it's 50% of the most deprived deciles, that's a really significant proportion of our population who have such poor health that it becomes an emergency for us to tackle it. So I'm being very emphatic about it, but that's because I think it's really these are important findings set out in a very clear way. Having said that, none of this was particularly unexpected from my perspective, working in public health. But I do think that, excuse me, some of the potential solutions that we've been putting in place to try and tackle health inequalities over the past few decades have been somewhat superficial or have been very much targeted at specific groups of people and their individual behaviours. So it's helpful again to have this call to action that's about going way beyond that. And I would urge government to pay attention to the report, and industry, actually. I'll start with the government, though, because if we're going to avoid the disaster that's predicted, then we really do need to do something about addressing the health inequalities. And we want to improve everybody's health. And it would actually be quite nice to think about that slide that we saw, you know, the one with the animation. You could see that, you know, one set of bars was growing quicker than the other. It made me think of an analogy about improving health being like being on an escalator. Do excuse me. You're on an escalator to good health. We all have the opportunity to improve our health. You know, wherever we are at the moment, there's an opportunity to make it somewhat better, manage better, reduce your risks, etc. And what we want actually is some people to be on a faster escalator, and that they all end up in a place where health is better, where they're living more of their lives in good health, even if they do have any of these major conditions, that they're managing those better, that they're being managed better by the health service, and that we're closing the gap in not just life expectancy and even healthy life expectancy, but in quality of life as well. And then to industry, just one last point, to industry, to employers, you do have a crucial role to play. We'll hear more about this later, but to help people stay in work, because that's good for their health as well.
Thanks, Sandra. And I was really struck by you were saying that, you know, to date, perhaps some of the measures that have been taken have been sort of superficial and targeted at specific groups. So when we come back to you in a moment, it'd be good to hear a little bit more of your thoughts of where a new government really can have some impact. But I'm going to move now to Nye from the Resolution Foundation, because again, just I think getting a little bit of that macro picture before we hear from a kind of employer perspective. But Nye, what's your reflections on this report and what it's telling us?
Well, thank you, Jo, and thank you very much, Anne, for that presentation. My first reflection was, you know, I'm not a health economist. I specialize in the labor market, thinking about low pay. But basically, since the pandemic, anyone doing any work in basically any public policy field has had to try to improve their knowledge about health inequalities. So I'm really grateful to be able to join panels like this and learn more about your work. It's very impressive work. I would say anytime anyone's willing to put their name to a forecast stretching much beyond the next few weeks or months is quite a bold thing to do. So, you know, fair enough. It's easy to sort of be a bit, you know, skeptical about long-term forecasts, but I think essentially what they do is they can shine a light on things that are happening now and tell us, you know, what will happen in the future, conditional on certain assumptions. And the key assumptions that I think presumably we're making in this work is if we don't fundamentally change the way we think about health in terms of our approach from policy or as individuals, this is what the future looks like. I think, so, you know, the headline finding for me was that inequalities aren't going to shrink or they're going to stay the same. And I was trying to think about, is that surprising? You know, in some senses, you might think that's better than a counterfactual of inequalities growing. But actually, I think my takeaway would be it's disappointing. You know, if we, for example, imagine that richer people, richer places are sort of closer towards the life expectancy frontier, I think might be the case, but, you know, Jo, as a health expert, will tell me if that's correct or not. You know, you might hope for catch up. You might hope that as we, you know, invest in our health services, find ways to improve lifestyles and so on, that there would be some kind of catch up. So I think a picture of no change in inequality is a depressing one, and I would hope that we can try and do better than that. And I wonder if other work in your project might reflect on, you know, if we did big policy changes like banning smoking, like raising the level of NHS investment, could we hope to do better than that picture of unchanging inequality? I wanted to just have one small reflection on how inequalities are measured. So the inequalities in this report are measured at the level of places, so poor places versus rich places. And I think that is very important to do. And obviously that's going to be very important for someone like Sandra, who's working in a specific place. But I was wondering if that, you know, actually understates the level of health inequality, because we know that in a poor place such as Hackney, which is actually where I grew up, there are both very poor people and very rich people. You can walk down a single street and see a housing estate, and then see some sort of fancy, grand Victorian buildings. So, having done a bit of background reading, I'm led to believe that's partly a data limitation. Things like, we don't have good connections of census data with death records and so on. But yeah, so I'm sort of wondering, what's the true picture of inequality if you don't do this sort of compression at measuring everyone within the same place? So maybe a little question for you there, Joe and Anne.
Great, thank you for that, Nye. And actually, a couple of things that you mentioned. One on the, as you said, one would hope that we would be closing inequalities in the future. There was actually a piece, I think, in the Times yesterday that was kind of debating, have we reached the limits of increasing longevity? And of course, the response to that is sort of, well, longevity for whom? Some people clearly probably have reached the limits of longevity, but I think what this report shows us is that there's a huge number of people in this country who aren't benefiting from that, and we're not going to change that very soon. And I think your point as well on the the deprivation versus, say, measures like socioeconomic status is an interesting one, and one, in fact, that colleagues in the Health Foundation are doing some work on and will hopefully publish soon. But I think when we come back to what would be interesting to, because obviously within deprivation, the sort of whole thing about people's income and so on is a factor. So it would be good to kind of come back and hear a little bit more on your thoughts on where government needs to be going with living wage and so on. But I'm going to turn now to Steve. And Steve, I think one of the things that this report really did highlight was the sort of early onset of ill health, that falling now much more into people's working lives, and therefore having implications for their ability to stay in work and contribute and, have, the purpose and fulfilling aspects that work gives us. And then very starkly seeing that in terms of that growth in working age ill health, we're seeing it falling on some of the poorest, most deprived populations particularly. But it'd be great to hear your reflections as an employer in terms of what you're seeing, and your reflections on the report from that perspective.
Yeah, thanks, Joe. And I agree with many of the comments that Nye and Sandra have already said. In the working age population, as a chief medical officer, part of my role is to look after all the colleagues currently at Jaguar Land Rover, but it's much, much wider than that. We are now looking after not just our colleagues, but their families, who will come from many of these deprived communities. A lot of our factories are in deprived areas, so our reach extends beyond the colleague right in front of us who helps to build our cars, but also into their communities and families and into the supply chain. So we have 10,000 suppliers ranging in size from small to big. And when we start to map that, we can see that we can have an influence much, much further than those people who actually walk into the factory gate, which may be Jaguar Land Rover employees, but are often from other organizations. And by targeting them and supporting them, what we hope to do is stop the slide that we often see. So Sandra's analogy of an escalator going up, we see the slide on the other side of that, despite everyone's efforts. And I think the report is showing this. Despite everyone's efforts across all sectors, public health, the NHS and support, once people start to develop those chronic conditions, which are very difficult to manage for the individual and for the health service and the people supporting them, they slide down the slide and eventually leave work without really strong specific interventions. And if we can get at them and support them while they're still at work, it's so much easier. The chance of success once they've fallen out of the workplace, we know, is much harder and more difficult. So while they're in work, we do have a role to play, we think, in prevention. We can see it much, much earlier. We can find them much earlier. All of the data points in the report we're seeing live, and we've got some examples of that we can talk about later. And the reach of industry is much broader than I think a lot of people think. For those colleagues who've worked in public health and the NHS, at the moment, the sharing and the best practice is quite difficult. We're not set up to do it. And I hope as we move forward, the new government will start to look at, it wants to shift out of hospital, and there is a win-win often in putting in support into the workplace, not just for the colleague in the workplace, but also for the family and the community. And we have done that, and we've done it successfully, and hopefully we'll be able to talk about that a little bit more. Thanks, Joe.
Yeah, great. I'll come back to you on that in a moment. So I'm going to pick out a few more specifics. And in fact, this chimes with one of the questions that a member of the audience has put forward. But to you, Sandra, I mean, what kind of public health action do you think could start to mitigate this? What would you like to see happen that would really get to heart of these issues?
Well, it's not a single action, obviously. These are complex issues and you can't solve it with simple or simplistic solutions. So we do need to do stuff at the individual level, like helping people to stop smoking, actually stopping people from starting, and dealing with all the individual risk factors that like obesity and smoking and drug and alcohol addiction that underlie many of these conditions that Anne was describing that are driving the health inequalities. Yeah, we need to do that. We have to remember that people don't live in isolation and that they live in families and communities. And we need to do a lot better, more effective work, which is actually really from the ground up, community-led work to help communities create health in their place. And that is really about both changing the way we think, but also changing some policies and funding flows that enable that to happen more effectively. In terms of health creation, from the Health Creation Alliance point of view, of which I'm a member, we talk about the 3 C's, which are connections, confidence, and control. And it's about enabling and supporting connections in communities, helping them to get confidence, gain confidence about not just their own lives, but their own environment, not just their own health, but their lives and their environment, and some control over that. And that includes how they interact with not just statutory organisations, but as Steve was saying, local employers, their own employer, and create conditions to build health at local level and at local government level and at national government level. We need to be creating the environment that enables communities to do that. So we're creating health. We're really doing some fundamental stuff that's about improving health and not just targeting individual risk factors and saying this is what we're going to do to create a no smoking environment or reverse the obesogenic environment, which are important things, but they are too superficial because they don't get to the core of what is really driving ill health. Obviously, there are those key things like employment and education and having good employment, having good education, having good housing. All of those are really important building blocks, but even within those, you still need to have that wider environment and particularly the social connections that give communities control over their own health.
Great, thank you, Sandra. Nye, just going back to you now. I mean, as I sort of said, the employment, income, all these things are important, we know, for people's health. You work on sort of labour market economics and the living wage particularly. What opportunities do you think policies on living wage and so on have to address some of these factors around people's experience of deprivation and what it's having on their health?
So it's a good question, Joe. If I was going to attempt to give a sort of a genuinely honest and humble answer to that, because I think it's always very easy in these kind of panel discussions to talk about associations that we know exist. We know that poorer people have worse health. We know that people in worse jobs have worse health, and we can draw these links across multiple, domains of social policy. But I think if you actually had to say, what can we completely confidently say as an intervention would improve health, I think it's much harder to be confident. For example, there was a really big review of health inequalities done by the IFS, which I read this morning, thinking, okay, this would give me some useful answers in case I get asked tricky health questions on the panel. that after 80,000 words, the conclusion in that report was this is all extremely complicated and it's really hard to sort of untangle the causal relationships that sit between employment, incomes, health. So I think with that said, it's only right that I'd be a bit humble and not overclaim. That being said, we certainly can observe that there are these links. So we know that people in really insecure, bad jobs are more likely to report things like stress, anxiety, more likely to say, at the end of the day, I feel used up. And of course, we know that being in poverty in itself can cause those kind of effects. And I think you don't need to think very hard to know why that is the case. So even if from a social science perspective, we can't be completely sure that addressing some of those things would improve health, I feel sort of happy enough to sort of say that those look like very plausible avenues for action. So in terms of what can you do to address poverty, what can you do to address job quality? I mean, poverty is very largely about how we run the benefit system, not entirely. And obviously you can look back to deeper causes, but if you want to make a difference in the short term, and I think most governments should want to just make a difference in the short term, it's largely about what's going on in the benefit system. So the government at the moment has got a commission on reducing child poverty. The answer is get rid of the 2-child benefit cap. Sometimes public policy isn't actually that complicated, and there are sort of some quite blinding answers in front of you. On employment policy, the government, to its credit, does have a number of plans for reform. In fact, literally tomorrow, we are expecting them to publish their employment bill. And I think they are going to do some useful things, but I think in some areas they probably might not go far enough. And I think that's possibly because they are shying away from those bits of reforms that might need them to spend money or might need employers to spend more money. So I think the useful things that they are going to do are to give workers on really insecure contracts a right to a regular contract. And I think that's good. It could remove some of the stress and anxiety that people face if they don't know how much I'm going to get paid from one week to the next. They're going to expand eligibility for statutory sick pay to the very lowest earners and get rid of waiting days. I think that's a really important policy change. In this country, our statutory sick pay system is wildly out of step with how all other rich countries run sick pay systems. So it's the need for reform is very serious. But what they're not planning to do is raise the level of sick pay. So it will continue to be the case that if your employer doesn't have an occupational sick pay scheme, you're on the statutory system, you will face a big income hit if you need to take, say, a week off work when you're ill. So I think that's sort of a missed opportunity to address that problem. The other big area, sorry, Joe, do nod at me if you need me to stop talking. The other big area of support of change is going to be on how the benefit system is administered, and, for example, what kinds of employment support are offered to people who are out of work. And we haven't heard much detail yet on this. We're not expecting, a big announcement tomorrow, for example. But, from what noises we've heard so far, they're encouraging. For example, we know that the government has hired a very good expert, Paul Gregg, who I know has worked with the Health Foundation in the past. So, he has lots of good ideas around employment support should happen more proactively, should happen much earlier in an individual's journey. It shouldn't be the case that someone spends, multiple years on benefits before they get given sort of high quality support. And he's also very keen on the idea that the main thing you should try to do, as I think we've already heard mentioned here, is to stop people ending up on incapacity benefits in the first place. The final thing I was going to say was, in the spirit of, can we avoid looming disasters? If you look at the long-term data on incapacity benefits, we saw a huge increase in the 80s and 90s. Basically, we got employment and benefits policy massively wrong in that era. And we saw a huge increase in the number of, particularly men, ending up on incapacity benefits. So I think what we've seen post-COVID is serious and concerning, but it's still dwarfed by that increase we saw in the 80s. So there's a sort of a real sort of burning platform type reason to sort of be thinking hard about these policy areas. So it's something I'm really hoping the government is going to get right.
Yeah, and I mean, that's quite nice that we heard in Anne's presentation that, things have been done in the past to have impact and have benefit. I don't think we have to feel entirely sort of futile and nothing can be done. There are lessons we can take and things we can act on. But I think what would be good, Steve, you alluded to the work you're doing at Jaguar Land Rover for employees and implications. As you say, you have huge number of people who are in your supply chains and so on. But it'd be great to get a sort of, really tangible feel of some of the things that you do and partners in the system are doing, and kind of what's working and what you think could be done more of by industry and employers.
Sure. A lot of what it started actually with COVID. So COVID forced huge social changes for all of us, and probably sped up and made us think differently. We started to work at that time with our local public health and our local NHS on delivering COVID vaccinations, not just to colleagues, but to their families. And that, I think that opened our minds up to the win-win here. You know, we have these people, they come to our sites, we're paying them. The NHS and public health needed to get at them, if we can use that term, and deliver a service or capture some data. And if we work together, we found that we were able to deliver programs that were needed, not just to the individual, but to their family, or go out into the community. And our ability to help people turn up or make them turn up is actually very good because we're paying them. It's a win-win for us because they're not leaving the workplace to go and do a health intervention that they might take half a day or a full day. They can just do it over the course of a half an hour or even an hour. So our shift went from being very reactive, we would wait for people to be off and then do something about it, to being much more proactive. So we started to invest in the ability to support colleagues with musculoskeletal treatment, with mental health treatment. They were our biggest risks. And we went out and started to collect the data that the NHS would try to collect, but often found it very difficult because people just don't turn up for their checks. They don't want to. It's very difficult. They can't get there. The transport's not possible. So we collected the data. We knew the health risks of the population and our supply chain, and we could offer the interventions there and then. So we have NHS liver vans come on and do scans. We look for pre-hypertensive, pre-diabetic. For the chronic conditions, we run a long COVID clinic and have done for many years, jointly with the NHS. So we triage and we treat the ones we can, and we work with the NHS for the ones we can't. We do rehabilitation and pro-habilitation programs. So for individuals who are overweight or obese and have absolutely no desire to go to the gym, as most of you, the people on the call will know, telling somebody to lose weight just doesn't work. It needs to be holistic. And we've heard from Nye and Sandra, it needs to be holistic. So we have to look at the whole person, the biopsychosocial approach about what do they need. Often it's one-on-one, but because they're in the workplace, we can make it, you know, part of their day. We give them the support they need, hopefully at the time they need it. We do run weight loss program management. We do run cardiac rehabilitation management. And we've convinced our leadership to continue to invest because we're able to show that return on investment and start to share the data back to the NHS and back to government to say, look, we think there's something here. This is a way of doing it. We also give a lot of our programs now to our supply chain. A lot of these companies are very small. They don't have the time, the money, or the expertise to offer these services. We can see that we do, often at very little additional cost to us. So by giving that to us, not only does it lead to better engagement with Jaguar Land Rover, but it also helps them supply us with a more consistent service. So it's a win-win. People benefit from a health perspective, the business benefits, and we can prove that and show that not to our financial director and to others who are interested. But it's not easy. And I think one of the things I hope this report is going to encourage is the drive to do more collaboration. At the moment, it only happens because there are individuals involved who really want to try and make it work and trial and show that this is possible. But it's not easy. The system isn't set up to do it. Government needs to do more to encourage it. And a lot of industries, not just Jaguar Land Rover, many industries and colleagues would like to do more with the right help and support.
Right. Just while I'm got you kind of on the microphone, there's a kind of very specific question. Somebody saying, Elizabeth Beach, saying it's great to hear you talk about the collaborative working with the NHS and public health on the vaccination, and specific question around flu vaccines.
Yes.
Yeah, that's part of what you're doing?
It is,
Yeah.
yeah. So we did COVID vaccine. We do flu vaccination. One of the learning lessons is people. We use a lot of behavioural nudges. People, as many of them on the call will know, people are often not anti-flu vaccine or other health interventions. I would include the NHS health check in there. But it needs to be easy. And if there's any friction, they just don't bother. So if we can capture them on their way in and out of work, our take-up rate of the flu vaccination is huge. We do a lot of work with our colleagues in the DE&I space to make sure we can explain to individuals why the flu vaccine or the NHS health check is worthwhile. And we have those opportunities to make it much easier. But the workplace, is often a great place to offer an intervention because it's easy. And the easier we can make it for people, the more likely they are to take up the intervention or the service, whatever that might be, including flu vaccination.
Yeah, great. Okay, there was, thanks for that, Steve. There was a question in the Q&A, which is kind of slightly more general question, and a number of you may have thoughts on it, but I'd probably start with you, Sandra, which is the observation was made that it's often hard to persuade Treasury, it was said, to focus on, yes, it said from a Treasury perspective, making the business case for targeting the most deprived areas compared to, say, people in the lower middle area is often difficult. And they're interested in reflections from the panel on where to focus effort. Where do we think by having some more targeted interventions there could be disproportionate value? And I guess because we're interested in reducing inequalities, it's got to go beyond the universal sort of offer and universal policies. Marmot talks about proportionate universalism. So there's something that we'd be interested in, kind of over and above what might be kind of a national policy. Where would you be advising government to really focus to close the inequality gap? So Sandra, could I hear some reflections from you first?
Yeah, so I think that it's not just about targeting the most deprived areas, as Nye rightly said earlier, that that it's not all people live in deprived areas, and you'll get more, you'll improve health more and close the gap quicker by really getting to the people in a proportionate way who have the most need, as opposed to the area that has the most need. And so I wouldn't necessarily say what we need is more services in deprived areas. What we actually need is a different approach to the way that we both target people for interventions, whether it's identifying and treating blood pressure or helping them to stop smoking, but also in the way that we think about how we deliver both public health and health services more generally. So health services have the disadvantage in the sense that they tend to be offered from static places, although, as we've just heard a really excellent example from Steve about how we can think more creatively about where we deliver those from, and therefore how you can get that more targeted approach to the people who most need it. In public health terms, we don't necessarily need to set up things that operate in a geographical way. We can think about at a local level, how do we understand our population in a more granular way? That doesn't necessarily mean only looking at routinely collected statistics, which iron out the issues sometimes, but also using the more grounded intelligence that we get from working more directly with our communities to understand what they need. But it's actually more about how you deliver it rather than whether you need to target money in a particular way. I would say that the business case to the Treasury is obvious, which is that if we're losing this many working days to the economy, this is how many billions of pounds that we're losing to the economy, and that if we manage to both improve health and keep people in work, we can close that gap. So that's the business case. Where should the money go? Into the public health system rather than into the healthcare service.
Great, thank you, Sandra.
And can I just add one other thing quickly,
sure.
which is that the problem's actually bigger than depicted, because in this report we've only really looked at people with diagnosed conditions. I say we.
Mm.
You've only looked at people with diagnosed conditions. So what about, there's all that unmet need, and we know that that's most likely to be greater in the people who live in the most deprived circumstances or in the most from the most marginalised communities. So there's an even bigger inequalities gap that we can't even measure. So the more we think about making sure that the way we deliver everything is more accessible and not so much targeted, but easier for people to get to grips with, which is why I really focus on the community-based approaches, then the more we're likely to improve the health of the people who have worst health.
Yeah, I'll come to you in a moment, Nigel. Just and just to say, there's been a couple of questions in the Q&A about maybe things the report did or didn't look at, but I'm going to come back to you in a moment, actually, just to sort of give your reflections on, yeah, sort of anything you think in terms of where the limitations have been and where you would like to see some more work going forward. So, Nye, I know you want to come in, you might want to speak to that point about targeting or something else, but please.
Yes, I just going to, on how you can help those who most need it. I spoke earlier about employment reforms, but I really think some of those would help in this agenda. I was going to kind of offer a bit of anecdotal evidence. So when I was doing work on sick pay recently, I spoke to a couple of building services management companies who employ cleaners, so very low paid people, mainly women. And these are the kinds of businesses who are most likely to have to pay more if government policy says, you know, we're going to raise the level of sick pay or we're going to change the policy. But these businesses had said that by doing it themselves and by doing some of the interventions exactly very, very similar to what Steve was describing. So letting people access healthcare at work, being proactive about pushing people towards those services. You know, they were reporting that people were able to recover faster, get healthcare sooner, because we know that, you know, it's not just that having a bad job might make you stressed, might make you unwell. It also makes it harder for you to access healthcare services. And I believe there's data showing that poor people are likely to wait longer through the path of their illness before they go and seek treatment, which you would assume would mean that the overall path of their illness is going to take longer, might have longer lasting effects and so on. So I think there are multiple ways in which improving people's experience of work, giving people more space in their day-to-day life, more control in their day-to-day life might help them access healthcare sooner and recover faster.
Great, yeah, thank you for that, Nye. Steve, I'm going to turn to you now. I'm actually going to pose a slightly different question. There's a question that was in the Q&A, which was targeted particularly at Jaguar Land Rover, but I think I'm going to make it a bit more generic because it is something that comes up about the role of industries that maybe in themselves are producing products that are having a potential impact on people's health. The example given was on size of cars, which is obviously something that's a big shift in the size of cars, and that has all sorts of implications for the environment and people's experience of the environment and roads and so on. But I wondered, your sort of reflections on how, as in the industry sector, you sort of manage maybe some of those tensions between looking after the health of your workforce, who are the sort of people directly in front of you you're employing, versus thinking about what might be some of the consequences of some of the products. You know, and I know you've worked in a range of industries, so I'm not asking you to kind of make it specific about cars, but how you know, from your insight, how are those tensions considered and addressed in the industry sector?
Yeah, I think a lot of organizations, sometimes there's a potential for conflict about, are they doing the right thing? Times are changing as well. Organizations across all sectors are much more interested now in how they can look after their staff for a whole number of reasons. You know, organizations are more mature in their understanding about what's happening in the health space. Well-being is the topic of the moment, probably the decade, but well-being as a term means so much to so many people that it's vague, but sometimes that's useful. Organisations do want to play their part generally in trying to improve the health of the communities they're in. A lot of them now have very strong CSR or other types of activities that don't necessarily conflict with the purpose of why they're there. They're all on a shift. Some are faster, some are slower, but they're all shifting. And I think most HR departments now are banging the drum that without good engagement, without looking after your people, you're not going to get the recruitment, particularly in the younger generations. So you're going to start to lose the people you need because they won't join you because you're not doing the right things. And they look for that. And we see that in our organization. We hear other organizations. So people come in and want to know what you're doing in many of these spaces. So you have to do it. But people want to do it. The speed of progress is different. I think organizations are still learning about how to do it. So a lot of what we do isn't being done yet in other organizations. Some are waiting for better data. Some need to convince their board or seek funding. But others are shifting. I saw there was a question about occupational health. Traditional occupational health, as it has been for the last 20 years, has been quite reactive. It needs to shift to being much more proactive, almost going back to how it was 50 or 80 years ago with the old ways of working, where it really truly was that in the workplace, you got looked after holistically and they didn't just concentrate on getting you back to work if you were off sick. And I think that direction of travel, which is look back to look forwards, is very much what organizations now think. They feel there is a part to play. They want to take part in it, irrespective of what type of industry they're in. And it's just looking for good examples of that because we're still quite early. So you need to go out and seek good examples. You need to build on the data that's out there from this report and from others and show that it can be done. So early leaders can show it can be done. You know, we hope we're one of those. We share it and show others the possibilities, including the NHS, that there is a different way of thinking, but it needs to be novel. You know, if we're stuck in traditional thinking, we're not going to fix this and we're not going to change some of the trajectories we can see. So it really does need to be quite novel thinking. We do target and test. And we test quite a lot. And I think it's one of the things that in health we haven't done very well. So we will often do small scale tests. And by the time we actually roll out the program, we're on version 15 or 20 because we've iterated and iterated and iterated. And that's not something we often see in health services that we need to copy from our colleagues who work in the digital landscape.
Thank you. Okay, Anne, I'm just going to turn to you because you know, we started with your presentation and you've heard the sort of discussion, the kinds of questions it's generated. And I'm wondering if you have some things you would like to reflect on.
Yeah, absolutely. Thank you, Joe. And yeah, just to echo, I think some of the points regarding the analysis that has actually come through from some of the panelists. So one of the things to say is that when we look at the conditions and the relationships between risk factors, actually only a very small portion of these patterns are being explained by the risk factors. And that's why I'm making the point about how, you know, the building blocks of health are also important, even though we're not able to put a number on, you know, how much of it is explained by things like income, education, employment. It is still quite important because, again, risk factors can only explain so much. And that's partly because of, I think there is still more research to be done. There are lots of areas of research in unpicking, even within risk factors, for instance, looking at anxiety and depression and the relationships between different risk factors, but also in terms of, like Nai mentioned, it's quite hard to causally evaluate, you know, how much of ill health can be explained by income or employment. And I think, again, there's lots of room for further research there. The point about the index of multiple deprivation, completely accept that. That is, again, something that has been raised, and we recognize that we're using an area-based measure rather than an individual-based measure. I mean, the gold standard for this kind of analysis would be if we are able to link health records with people's income or people's occupation, and that would provide for a much richer, detailed analysis where we can trace these relationships back to the individual level. But unfortunately, data limitations mean that, you know, it's the index of multiple deprivation is something that's sort of easily accessible and linkable to health records. And that's why we're doing this. But I know that the Office for National Statistics is doing all of this work to combine a lot of administrative statistics. So eventually we could reach a future where all of that kind of research becomes much more accessible. And to Sandra's point about whether we are potentially underestimating the extent of inequalities by looking at diagnosed illness, I think, yes, that's probably right, in the sense that we are looking at only illness that's recorded in healthcare. If we, for instance, know that there is a higher likelihood of people in more deprived areas facing barriers to even accessing care because of a whole range of different reasons, then obviously, like Sandra mentioned, that is going to be unmet need. That illness is not going to be even picked up by healthcare records. And so potentially by looking at the kind of data that we're looking at, we are potentially underestimating the extent of health inequalities. So just I think some clarification points regarding some of the analysis. And also just to say, when we talk about health inequalities, again, it can be defined in many different ways. So here specifically, we're looking at health outcomes, but you could also look at, for instance, what is the quality of care that people get, or what is for a given condition, how much healthcare do you use, or how complex is your condition? So there are a whole range of things. Even when we talk about health inequalities, it's quite a catch-all term. But if you go into the detail of it, there are lots of nuances in terms of how you measure these things. And we are obviously looking at just one aspect of it. We're looking at inequalities and health outcomes by socioeconomic deprivation, but we have a whole range of different topics underlying health inequalities.
Right. Thank you, Anne. And I should say thanks again to Toby, who has answered, as things stand at the moment, 27 of the questions live in the chat. So thank you for that, Toby. So we're coming to the end now. I think I'll just share a few reflections and then thank our panel. So I hope people have, through this, sort of really understood the sort of richness and complexity of what the report's trying to do, and that actually I think it does generate quite a lot of debate and discussion. I've been struck in the chat, that people haven't, in the Q&A, people haven't kind of been asking about one issue. It's just sort of opened the floodgates of all sorts of questions. And I think that's testament really to what an interesting report it is. Thank you to our speakers. I think it's been really good to sort of get these different perspectives, sort of understanding the difference between, thinking about place, thinking about populations within a place, really thinking about some of the sort of the way in which actually investing in communities and giving communities those assets that Sandra described as being quite fundamental, that we can't always think about just layering on more and more services without really thinking about how we're putting power with communities. I felt quite an optimistic note from Nye in terms of some of the opportunities that the current government can grasp, and hopefully we will see being grasped around welfare reform and employment. And I think really good to understand through Steve how some of the big employers working also with their supply chains can really start to have an impact, and particularly that partnership with the NHS, I think was really encouraging and positive to see. So a big thank you to Anne for her presentation, Steve, Sandra and Nye for their contributions on the panel, and thank you to everyone who joined this session. Thank you very much.